and welcome to Inspire Ask an
Oh, we're live now. Sorry.
Good afternoon.
There
Take
you go.
two. Welcome to today's Ask an Expert panel discussion from Inspire Respiratory Therapy Critical Care. My name is Keith Lamb. We're going to go around the room here real quick. My name is Keith from Virginia. Tom?
I'm RT from Canada, Ontario, Canada.
Brady?
Brady Scott, RT in Chicago.
Joel?
Joel Brown here in Delaware.
Andy?
Good afternoon, Andy Klein, respiratory therapist, also from Chicago.
And Eric?
Hello there, Eric Reiner. I am from DC.
So again, welcome to all the listeners out there. Feel free to post comments in the comment section, and we will certainly try to get to any kind of questions or discussion points that you might bring up. Today's discussion is surrounding scoring systems that we use in critical care.
And if you're in the chat, please just shout out where you're from.
Yes.
Be nice to see you.
We'd like to meet
where
all.
you're from.
So welcome. Ask an Expert, scoring systems in critical care. We are going to, I want to go ahead and list kind of list what we're going to talk about first, Tom. And then, what we're going to do is we're going to list some of these things. We're going to talk more about the ones that specifically impact our area of expertise. And we'll also talk about some of the other ones that, and we'll tell you why we're talking about those also at the same time. So I'll get us started, I guess, with the PF ratio. I think this is probably one of the scoring system type indices that most of us are familiar with. I don't know about the rest of the panel, but I think that the first time I became familiar with this was back when the Berlin definition of ARDS first was sort of introduced. At least that's the first time I had seen it. And if we remember way back, I think that it was, 2012 maybe ish. And, the part of the definition, the ARDS definition was to look at the PF ratio and PF ratio less than 100. So PaO2 divided by FiO2, simple math. If the PO2 is 100, let's make it 99, and the FiO2 is 100%, then that would be a PF ratio of 99. So back during the initial attempt at defining ARDS via the Berlin definition, a PF ratio of less than 100 was severe, a PF greater than 100, less than 200 was moderate. And then actually, I think back then, if I remember correctly, we still used lung injury as the definition of greater than 200, but less than 300.
Yeah, 200 to 300 was acute lung injury. And then just out of simplicity, when the Berlin definition was defined, they changed that to mild ARDS.
Right.
So any PF ratio below 300 would constitute as ARDS, and then severity would be split up. Now, interestingly enough, just prior to the Berlin definition getting published, for example, the ProSEVA study, which is the proning study that everybody quotes, this was just prior. I think when they started the study, the Berlin definition hadn't come out, but just before it was published, the Berlin definition came out, and most studies had actually quantified severe ARDS as a PF ratio less than 150. And this is actually an important point when you're looking at some of those other studies. When we say, prone positionings for severe ARDS, if you go by current definitions, you might think that's less than 100. But the best study we have to date did it with PF ratio less than 150. And I actually did a pro-con debate years ago at AARC about this. And my argument was to prone for moderate ARDS. And luckily I had that ProSEVA study had published sort of some subgroup analyses, and they looked at patients with PF ratios between 100 and 150, which would have classified as moderate ARDS, and they had a significant benefit to prone positioning. So the argument is to essentially keep it at 150 if you're going to decide to prone a patient. Still use that cutoff of 150. Don't just go with severe ARDS with the most recent definition of less than 100.
Anybody else on the panel clinically use the PF ratio? Eric?
Yeah, all the time.
Yeah.
All the time.
I think that's probably ever
It's-
since COVID, and you guys can agree or disagree, but I think since COVID, the biggest use of the PF ratio has been looking for that 150 and decide whether or not to prone. I mean, at least it was during COVID. I think people are, unfortunately, and I'm gonna highlight that word, unfortunately, falling back away from that again. I think we're sitting on patients too long, whereas when COVID was at its peak, we didn't hesitate. We just prone the patients. And I think we're starting to stray away from that, where we're trying other unproven strategies when someone is hypoxic instead of saying, hey, you know what, the best evidence we have is to prone this patient. And maybe that's not across the board, but I just sort of felt that, people were starting to shy away from it again, and that's pretty unfortunate.
Yeah, I would totally agree with you, Tom. I mean, we've slidden backwards in terms, just observationally, anecdotally,
Yeah, I don't have any hard evidence to support that, but
no,
I feel like
just-
anecdotally it seemed like it was starting to not be the first thing we suggested, whereas it definitely was for, nearly 2 full years.
It felt like it was top of mind all the time for several years. And, as I kind of go around now, I'm like, I'll often come up to somebody or a case and be like, so why are we not proning? What are we not doing? Was there something that I missed here? And it was like, oh yeah, that's right.
We're going to start
Flowland.
We're going to start Flowland or Carapool. It's why aren't we proning the patient?
Yeah. Flowland. Excellent.
And it's kind of within our escalation algorithm, going all the way up to severe respiratory failure towards ECMO for, all right, now we're going to layer this on and that's that type of thing. For better or for worse, proving efficacy of, this gross, 30,000 foot view of efficacy of whatever therapy, whatever modality that you're trying at that particular moment type of thing. If you're proning and your PF ratio still is in the toilet, we're going to layer something else on. And if it's still in the toilet, then we're going to continue to layer type of thing. But if you get a bounce in your PF, we kind of walk away, unfortunately, until you start to dig a little deeper and get into the weeds with them about, some of the details. We'll stop if we have a positive response for the PF ratio, right? So yeah, we use it a lot.
I think an important distinction to add too, Keith, with this is in context of how much support they're on too, right? Because if they're on 30% oxygen in a PEEPA 5 and their PF ratio is 148, that means something different than if they're on 100% in a PEEPA 16, right? So, and even the Prosiva trial specified, right, 60% in a PEEPA of at least 5 in order to make the distinction that your PF ratio is poor. To make those decisions. So always be aware of how much support they're getting too, and don't, take it with a grain of salt if they're on very minimal support.
Yeah, I think that's where the OI comes in, right? We'll talk about that soon. But in terms of the PF ratio, Tom, you talked a lot about, and you and Eric both talked a lot about proning. What's the utility in using the PF ratio in awake proning? I bet Brady has something to say about this, maybe.
Didn't you guys study this, Brady? I feel like this is a question for Brady.
So you talk about awake prone positioning?
Yeah.
You use the PF ratio, or you put up the slide on SF, so I was confused about that.
Yeah, sorry, that was my bad.
No, that's okay. I think that it went back for us to, it was a way for us to monitor disease progression, to get some idea of maybe when to. I got to be careful here because I don't think we ever got this one nailed down, Andy. Right? When to intubate somebody, but I think that we could at least monitor disease progression, or see things changing over time. My mind went to the SF ratio, which is probably useful too, as long as your pulse oximeter is actually reading accurately, and we know that there's all kinds of problems with that. And so, but one of the things I wanted to mention, for those of you on here that don't know me very well, I spend most of my time in academics. I was actually going to say I like to use the SF ratio and the PF ratio to help conceptualize for the students to understand like severity of the situation that they're in. Like, for example, if a student tells me that a patient has a PaO2 of 80, when they're learning normal values, that seems good. And so I make them start to talk, in class, we start to say, well, my PaO2 is 80 on 80% oxygen, right? So this is a PF ratio, and then they start really to look at kind of like, yeah, you're right. I am normal. I'm normoxic, but it's taking 80% oxygen to create the situation that I'm in. So they're actually in a pretty severe state or a pretty sick state. So I think
it adds that clinical context, right?
100%. I just think it's such, and even early on in training. So, I mean, we just wrapped up a semester where we start out in our first semester with cardiopulmonary anatomy and physiology. And I introduced these concepts of like PF ratio and SF ratio right in the first semester. And when we're talking about how sick patients get. So, and then that will transfer into, Andy next semester has a patient assessment class where we'll start to bring these indices and other measures like this in to help draw the clinical picture. So I think PF ratio is a really good one. It's very simple, it's easy, and it's something we can talk about a lot in the classroom.
Yeah, I think so. So you really bring up good points about, my PO2 is the patient's PO2 is 80. That's awesome. But then when you calculate a PF ratio of 80 on 100% FiO2, that doesn't sound as awesome. And then when you look at the oxygen index or oxygenation index, and your PO2 is 80, your FiO2 is 100%, and your mean airway pressure is 30. Okay, then that is significant. And so I think if I were teaching this like you, Brady and Andy, then I think that's a good way of sort of ramping up and showing the significance of the different levels of support. And you can go the other way too, right? I've taught many times where, you see somebody that's on that's on, let's say they're on 6-liter nasal cannula on the floor. They're chronically hypoxemic. They're chronically acute on chronic hypercarbic. And that PF ratio that they would have, their PO2 could be 60 on almost 50% FiO2. Their PF ratio may calculate as, moderate ARDS, but they're at baseline. They walk around the mall like that with a PO2 of 60 on 44% FiO2. So I think you can show the extremes in both, on both ends of that scale that way. And that's a really important concept for somebody who's a new clinician or a clinician in training.
Yep.
The SF ratio. So another sort of point about the PF ratio and then the SF ratio, as we all know, as long as the numbers aren't in extremis, that the SF ratio, I believe the median difference between SF and PF is about 30, maybe. Somewhere between 20 and 30.
PF ratio of 300, I think, is around 315, at least in the one paper that compared them closely. It was 315 for SF ratio. And then for 200, it's 235. And then for severe, for 100, it's 44. So the gap gets larger the lower the PF ratio or the SF ratio, the larger the gap is from the normal value.
Right. For my taste, for my clinical experience and acumen and however you want to put it, when I'm seeing a patient, that number seems to be sensitive enough to me, like to get the idea, right? I just want a general, it's like we would all sort of agree that when you go in to see a patient, the way a patient looks is probably the most significant finding that you're going to, and useful thing that you're going to get at first. And if I know, I don't, again, we talked a little bit about blood gases at the beginning. I don't need a blood gas to calculate the SF ratio. And I can see that if my patient's saturation is 92%, and they're on a 60% high flow nasal cannula system, for instance, then I sort of get the idea, right? Where they stand. And so for me, the SF ratio is fairly sensitive, at least sensitive enough.
Yeah, I think as long as we're very aware of some considerations, and Pablo's got some in the chat that we should make sure that we don't miss before we get too deep into it. But one of them, of course, is the accuracy of the SAT monitor. Not only based on skin color, et cetera, but just that there was a nice study published in Respiratory Care that shows some monitors can be off by about 4%. So this is important. The other thing is this value is useless if your patient sats are 100, right? So your saturation has to be low. And most of the studies looked at a cutoff of 96 or 97% saturation. So if your patient's satting 98 to 100, you should consider not using it, or it may in fact give you a false sense of what the actual SF ratio is. So clearly, if the sats are 100, your PO2 could be anywhere from 90 to 150. You have no idea. So you lose that correlation with the PF ratio when your sats are high. So just something to consider. So one of the questions was, do we need an ABG? I think just before we went live, we were all talking about how when we first started practicing, it was an ABG for everything. And now we're all talking about how we hardly ever use ABGs, except perhaps in the context of proning a severe ARDS patient who's intubated. You might utilize that daily blood gas, again, drawn sort of before and after prone positioning. But otherwise, the SF ratio seems to be reasonable, keeping in mind that, you can't go up to a patient satting 98, 99 and expect to get a useful information from that.
Yeah, I've been a big fan of the SF ratio, especially being my background in peds. And so I find that, it gives a good way that you could just take a quick look and then know if you need to draw I see a lot of people, do we need ABGs? I see a lot of that. It gives you that indicator like, hey, I need to do something else, or I need to maybe there's a change going on without having to wait for an ABG to come back, so you can get a PaO2. So for a quick bedside look, and figuring out, like, if you want to get a quick look at how things are going, especially once the patient stabilized, I'm a big fan of SF.
I think blood gases will still be largely used for clinical studies as well, just to ensure that they're properly defining characteristics and inclusion criteria. We're going to get into some other severity scores that are not specific to respiratory, but include respiratory parameters. And a lot of them include the amount of oxygen they're on, as well as their oxygenation status as per PaO2.
I don't think we'll ever get away from using ABGs whenever there's a clinical. We have to acknowledge the limitations of pulse oximetry. I think with pulse oximetry, which I love it, use it every time I go to the bedside, you have to realize what it can't do as much as what it can do. And so that means that there has to be some critical thinking involved here to say, you know what, I believe I do need to get a blood gas because of the current known limitations of the devices and the patient condition. So there would never be a time, I think, any of us will totally throw out blood gases. But for folks to know, we were joking, or kind of not joking, to be honest, early in our careers. I really relied on pulse oximetry blood gas analysis before I could I was paralyzed by not having numbers. And then I had more experienced RTs tell me that, seeing a patient, breathing 35 times a minute with a SAT of 65, diaphoretic and speaking in short sentences, I didn't need a blood gas to realize they were having trouble breathing. Right. I have a whole lot of other indicators that would suggest that to be true. I just think it's important for us to make sure that we, acknowledge that blood gases are the gold standard in terms of measuring SaO2 and PaO2. And we still have a way to go, I think, with pulse oximetry. And if anybody was at the ARC conference, Michael Lipnick gave just a phenomenal talk on the current state of pulse oximetry. Probably one of the best talks I've ever seen on the topic. It was really eye-opening. It looks like there's some positives, right? There's some good work being done, but we still have a way to go.
Yeah, his talk was very eye-opening. And I actually talked to him a little bit after. I walked up and talked to him a little bit after and just told him how much I feel like I don't know now than I did before. But that all being said, Brady and I, when we were in Riyadh not too long ago, we had a mini debate about blood gases, and it was more not because we disagreed with each other, but we were trying to prove a point. to a classroom of a class of learners that, if I go see a patient, let's say I get called for a Met call or RRT, whatever you call it at your institution, and I get called out to see a patient and they're breathing 45 times a minute. Their nasal flare, and they're using accessory muscles, their saturations, whatever, doesn't matter. But they look horrible. And I get a blood gas and it's 7.4 and the CO2 is 40. Am I using that blood gas to decide clinical intervention? No, I'm not. But I'm going to support that patient regardless of what their blood gas, because they're working really, really hard to get a PO2 of 40, to get a CO2 of 40. And conversely, if I go out to see a patient and they're doing the Wall Street Journal crossword puzzle, and they're having a real lucid conversation with me, and I draw this blood gas and it's 7.2 with a CO2 of 70, am I gonna invasively intervene with that patient?
Well, have you checked their crossword puzzle?
Oh yeah, right.
Maybe
Whatever.
they need more oxygen. I don't know. I don't know what they're writing in those boxes.
Whatever it is better than I would be doing. So regardless. So anyway, numbers are numbers, and we need to make sure that we're utilizing the data that we get in a way that's most advantageous to the patient, right? And so it's not always something that we should be using.
Do any of you remember which lecture Dr. Lipnick did? Like, is it going to be a paper? Is it it'll be?
Yes, it will be a paper. It was
Okay.
it was one of the plenary sessions, I think.
Okay, I wasn't sure because
It was
some
the
plenaries
Kittredge
are
lecture.
follow-ups. Okay, so
Pretty
yeah,
sure it
it'll
was
be
Kittredge.
Yeah.
So
Yeah.
it will follow up with a paper. But to be honest, Dr. Lipnick and his team have several papers on this topic that are just terrific. And so that hypoxia lab, and I think it's UCSF. They've been doing a lot of work in that space for many years, and they're kind of leading the way there. So yeah, that will come with a paper. I look forward to reading it.
It's great.
I'll post another one too. I think if anybody's interested, that his team wrote, so if anybody has any interest in this type of thing, I'll post another one here in the chat.
Yeah, that's really good stuff. So having said that, before we move on from the PF ratio, what's its utility in research? Since we just talked about Dr. Lipnick's lecture, what's the utility in using the PF ratio in the research?
I mean, I actually missed Dr. Lipnick's lecture. That's why I asked if it was coming out for paper. It wasn't just for the listeners. It was, or the watchers of this. It was actually for myself. But in clinical research, mostly it's due to some of the scores we're going to talk about in a bit, at least the requirement of a PaO2. And then specifically for ARDS studies, they're classifying, usually it's used for inclusion criteria. That's if it's an ARDS study, then the first thing is they have to, either, now let me backtrack a bit. Some studies that are maybe not labeled ARDS, but they're labeled hypoxemic respiratory failure patients. They're capturing the PF ratio, but they're not requiring, for example, a strict definition of the Berlin definition of ARDS, for example. They're just enrolling patients who are hypoxic, and this is what they're using in clinical research to define the degree of hypoxemia is the PF ratio. It's not just the PO2. Again, to put the context there with not just the PO2, but how much FiO2 they're on for that. So that's generally the use is for enrollment criteria.
Yeah, so I agree. I mean, I think it's helpful. It's helpful to use in order to sort of sequester types of patients and stratify patient severity of illness to some extent. And it's a real easy. So if you're going back and looking, if you're retrospectively going back to look, PF ratios are easy to find, right? Easy to find, a lot easier to find than some of these other things that may or may not have been calculated back retrospectively. So some utility in research for sure, maybe not as much utility in introducing specific clinical interventions, at least in my world.
Except proning.
Except proning.
What about ECMO?
PF ratio for ECMO? No, I think as we go forward here, I think there are some things that we can look at that are a little more useful for sort of using as a screening tool for ECMO, at least in my experience.
Yeah, we
I think
use
in ECMO
OI and-
studies, it's a requirement. I think they did the AOLA study, they do less than 150 or less than 100 for PF ratio?
I think in some of the guidelines, Tom, it uses 80 for criteria for ECMO.
For ECMO, yeah.
80.
I wasn't sure because what the I don't know if I'm saying it right. The AOLA study it was a little bit I want to say a little bit more, not conservative, a little bit more liberal with their use. I'm gonna have to look it up here.
And there was a considerable amount of crossover, if I remember. I haven't looked at that data in quite some time, but there were not an insignificant number of patients that crossed over from conventional therapy to ECMO.
The OLA trial used it was even more severe, and it had two different ones. It was PF less than 150 for a certain amount of time, short period of time, or PF less than 80 for a longer period of time, so that you could get in quicker. I think those were the inclusion criteria. If you were really sick, you didn't have to wait it out 6 hours to prove yourself that you were getting ready to die, type of thing.
Right.
Right. And so I think it had two different ones. The OLA. Now you gave it to me, Tom. I was fine before, but it had two different ones. One was a short term, one was a longer term one. And I believe it was less than 50 and less than 80 for the short term versus longer term, respectively.
Okay, I couldn't remember if they were a little bit more forgiving with their inclusion criteria.
They were
I wasn't
actually
sure if they
much stricter. Yeah, we use OI and REST scores for ECMO.
Yeah, and we'll talk about OI in a bit if we get to that one. We're already halfway through. Keith's like, I'm not sure we're going to make it to an hour. It's 30 minutes. We're still on the first one.
I guess we can move
We're
forward.
still talking about
Yeah.
the old PF ratio. 30 minutes.
Yeah, we're all just in love with the PF ratio.
So I think,
I
I
guess
think
so.
before we actually do move on, though, I think for the people who are participating with us here today, I think an important thing to understand is the SF ratio is not perfect. The PF ratio is not perfect. If you don't have arterial access, the SF ratio is most likely sensitive enough to give you an idea about what's going on and maybe trendable, right? And so that I think that's the utility of the SF ratio. Save somebody a stick.
Yep. All right. Here's the oxygenation index, which
So
I can honestly say I think I've used it once in my clinical career. I felt like it was always used in pediatrics. I always knew friends that used it in pediatrics, but in adult patients, when a couple of times we consider it when we were using the oscillator, this is pre the oscillate trial, before the oscillate trial, and it wasn't even reason to put it on there. It's just once they were on it, because we had a map value, like it was very easily, like that's literally was our setting. It was like sort of our severity measure for it. But since not using the oscillator, it's been years since I've calculated that.
I think we use it because we use a decent amount of APRV, though, and that's just based on our
Well, that's another
institution,
problem.
You know, yeah, sure. You know, so that you can go apples to apples across all of them, regardless of the mode. So,
yeah, I think if you're using a strategy that it's supposed to be aiming at a open lung approach, then this could be helpful.
mhm.
Hence why it was used for HFO, and you know, the fact that it's used for another open lung approach like APRV. I think we need studies like we have for the HFO to see whether or not we're doing the right thing. But for ECMO, obviously the severity, I think the PF ratio works well for that, particularly if they're using cutoffs that are below 100. It's hard to fake that in terms of your severity of illness. And many of the patients that end up on ECMO don't tolerate, many of them, they've already tried a higher open lung style approach. Usually people have tried either higher levels of PEEP or perhaps they've tried APRV. The question is, have they tried proning? Because that's really the what should be done prior to doing any of the other stuff. But as a screening for severity, do you use it for your inclusion criteria for ECMO, Eric, or is it still mostly the PF ratio?
I would say they use it. It's on the list. How would I put this? I think they use it more for exclusionary criteria. Like, no, they're not quite sick enough yet. That's where they fall into most of the time, right? Like when they're fighting a cannulation for us, and they're not excited about cannulating. They'll go back to it. But typically, we're looking for greater than 35-40, and a REST score that is something that does not that still bodes well. So we use both of them hand in hand.
What about you, Keith? You guys does everybody here work in a center that does ECMO? So you guys do it at Rush, and Keith, you do as well?
At UVA, they do.
Okay.
I recently left UVA a few weeks ago, but
okay.
Yeah.
Are you utilizing the OI there?
Yes. And
They
For
monitor.
ECMO? Sorry, Andy, you say that as well?
They monitor and trend here as well. Yes.
Okay. Is it part of the inclusion criteria, or it's just a consideration essentially?
Consideration. I mean, without talking to CV surgery, they seem to sort of have their own criteria that the rest of us have trouble following sometimes, because it seems like they'll pick a patient that we're like, how is this person on ECMO? And then somebody that seems like a slam dunk, they'll decline. So, but I do know that is on their checklist of things to monitor and take into consideration when making that decision.
So it's not just me. It's not just here.
Not just you. I do question.
Yeah, that's why I was asking. I just wanted to see if that was an overall.
I do question though for the people that do. I know Keith is this is his wheelhouse. In my mind, it has less utility once they're on ECMO, right? Because we're backing the vent completely off at that point, so we don't. It doesn't have the same value then, right?
Yeah, I would completely agree with that. I
the
think the
oxygen.
origin. I think the people who first started to use the OI. I can't remember who already mentioned this, but were the PEDS people, and they used it as a sort of a screening tool for high frequency. And so once the adult world sort of saw that data, it sparked some interest. I will tell you that several years ago, when I helped to start an ECMO program out in Iowa, we needed to collect some data to sell the whole idea to the C-suite. We thought it was a good idea to provide ECMO. We thought we had a lot of sick patients that would benefit from it, and so we started to look at we started to look at some retrospective data, and then compared to the ELSO data that had already been collected. And what we found was we looked at about 1,200 patients, retrospective patients that had hypoxemic respiratory failure at our institution over the last few years, and then compared it to people in the ELSO registry for people who may be on the meeting that don't know what that is. That's a sort of a database that ECMO centers submit their data to. So when we looked at that, what we realized was that we had 100% mortality in any patient that had hypoxemic respiratory failure with an OI of greater than 25 for 48 hours. That was 100% mortality. And we went and looked at the ELSO data and realized that most people with an OI of 25 did not die if they got put on ECMO within that 48-hour period of time. So as a result of that, we started to implement the OI in our consult trigger. So if somebody reached an OI of 25, or was quickly approaching, or was over, or whatever, then we started to look deeper. Not that we weren't already looking at these patients, but we started to look more deeply at the etiology of the respiratory failure, right? So if somebody had eosinophilic pneumonia, for instance, people don't typically die of that. They get sick from it, and then it gets treated with steroids, et cetera, and then they get better, right? So we looked at people with OIs of 25 or greater. Why did they have that OI? If it was, primary ARDS, then that's a legit player, right? And that person's not going to get better within 24 hours. And we probably would trigger, if there was no contraindications to it, we probably would ECMO those people. So I think that, in my mind, the utility of the OI, sort of the advantage of the OI is it gets rid of that whole Mall Walker PF ratio patient that I was talking about at the very beginning, and tells you that, hey, this isn't the Mall Walker with the PO2 of 55 on 6 liters. This is somebody who is sick and is on 20 a peep to get that. We don't use the oscillator in adults anymore, thankfully. Knock on fake wood that my desk is made out of. But it just seems to me to be a more sensitive approach at looking to see how sick somebody is and whether or not you should be proning or placing on, ECMO. My 2 cents.
Well, I think point taken, and I would agree. I mean, especially since, we use a lot of transpulmonary pressure guided PEEP. We end up on hefty levels of PEEP, and you're masking the severity if you're only going by the PF ratio because you haven't included necessarily the mean airway pressure that goes into that equation, essentially, right? And so I think that's kind of what you're talking about, and and so it is absolutely not a make or break for us. It is part of the picture, because even the RESP scores, the ref scores, don't include a driving pressure or anything else like that. All these other markers of potentially injurious ventilation. But I found it to be useful in arguments more so than not, right? Because of our PEEP strategies or our other ventilatory strategies that, as we're marching our way up from evidence-based guidelines to kitchen sink modalities prior to ECMO, which they want to see, they always want to see you do everything before you get there type of deal. It just kind of strengthens the argument a little bit more, I would say, to somebody that knows what you're talking about, even too, sometimes.
Yeah.
Right.
Yep.
I look at you like, what?
All right. Well, let's shift over to the OSI, which I definitely have never used.
Yeah.
Which
never used it either.
Similar to the PF ratio, swapping out the the PO2 for a SAT.
Yeah.
We've got the OSI.
Mm-hmm.
I'm curious if anyone in the chat has used this measure. I certainly have not. Has anyone in our chat, in our panel? Everyone's shaking their head. No. Eric, have you used it? Nope. There's the shake. So none of us have used it. I'm curious if anybody in the chat had used it. I had not even actually heard about this. Now, in my defense, and probably most people's defense, if you're not using OI, there's a good reason you don't know what the OSI is, because you're not used to using it. So.
Well, if you're at the level of curiosity for the patient that you're concerned about mean airway pressure and all the other things, why would you trust a SAT?
Yeah, right. So I was gonna sort of say the same thing.
Yeah, it's like you're that using a SF makes you go but then after that, after that if you're truly that curious, I would just wouldn't be something.
Yeah, so Pablo's saying PEDS, and that's if you live in that, if you work in that world and you are using OI, then chances are someone has discussed, hey, can we do this without drawing blood, and can we just use the SAT? So obviously they're interested in a measure like this. But we probably don't need to dwell on it, since most of us have no idea what we're talking about with this one. So
yeah, I'll just say that when you look this up, what you'll find that the data is almost 100% in PEDS. and
Right.
the stuff that's been written on it. And I think I'd be putting an arterial line in somebody. Most certainly would be putting an arterial line in an adult that I was thinking I really need to know what the OI. I need to know. I need this level of data to.
Yeah, these aren't patients where you're typically needing to actually stick them for an ABG. Like these are generally once you're doing even an OI, generally these patients have vascular access that you can quickly draw off a PO2 without having to put them through much more trouble.
Yep.
Pablo thinks there might be an ongoing study that is using it.
Yeah. Thanks, Bob.
All right. These are just a comparison slide between the two values.
Yeah, just a comparison slide. The OSI is to the OI what the SF is to the PF, essentially. If and something we didn't mention regarding the SF, and I don't really want to go back again for very long here, but is that the newer definitions of ARDS are using that as an option, right? Because they've implemented several options that weren't really involved in the most recent, previous to that, the most recent guidelines for ARDS. So, they're understanding that sometimes you don't have arterial access. They're understanding that sometimes you don't have really good imaging that's available to you at the bedside, maybe other than POCUS. But yeah, so that's what this slide is, just a comparison between the two. And you can see that they're, you could use either one probably to get data. But again, I would be putting an A line in somebody that I was really this concerned about.
Yeah.
ROX index. Anybody use the ROX index?
I used it clinically during COVID, but not as a deal breaker for intubating patients, but definitely would trend it, particularly in the first day, because a lot of the value was within 2, 6, and 12 hours. So once I started somebody on high flow, I would trend it over the length of my shift. And then if I came back the next day and it was even worse or has not improved, I would just let the team know that this patient is not doing well. And if you want an objective number, here's an objective number, but you can just walk in the room and look at them. They look like crap. I can tell you there was at least 2 situations in particular that I remember using this and mentioning it multiple times, and the decision still was not to intubate this patient. And then once they finally did, like a week and a half later, the patient did not do well on mechanical ventilation. I think we waited way too long. And I'm sure some of us probably had many patients that we felt, at the beginning of the pandemic, everybody felt that we were intubating people too early. And then I think the pendulum swung way to the other side where we were just waiting too long. Now we're just saying, oh no, because everyone had that one patient that was just on high FiO2 for a long period of time and they ended up doing okay. But then there was a number of patients that didn't. And I think the fact that this includes respiratory rate really helps, because by the time your resp rate goes up and increases, generally, you're really not doing that well once it's at a significant level. So, and there's some nice examples there of, having a SAT of 95 versus 88, on 40 to 80%. But yeah, it predicts high flow nasal cannula failure. It has reasonable diagnostic accuracy, but one thing I will point out that these cutoff points that you have here, Keith, are from the paper that published this. And the inclusion for that paper was these patients were requiring high flow nasal cannula for the purpose of their respiratory failure was secondary to pneumonia. So they had a diagnosis of pneumonia. So in terms of generalizing this ROX index for any patient with hypoxemic issues, that's problematic in itself, because the study only included patients with pneumonia as their reason for ICU admission.
I really like it because it adds the respiratory rate. I think that the evidence would suggest that respiratory rate itself is largely undervalued and underappreciated. I think, Tom, you and I presented on this topic, and I think you were one of the reviewers on a paper, because you led the group on monitoring of one of our journal conferences. The respiratory rate is really underappreciated.
Yeah.
Once I had a colleague in a different state telling me how he's a critical care physician, and they have an interesting way of using the ROX index in his hospital. Is when the like hospitalists are having a little, so they do high flow nasal cannula oxygen therapy on their general care wards. And again, I'm not telling everybody to go do this, so let me just put that disclaimer out there. But the hospitalists actually use it to as a trending value in monitoring. They calculate it fairly regularly, and it really creates a situation where they call into the ICU to see it going one way or the other, to prompt earlier discussions about maybe moving somebody into critical care. But again, I'm not telling everybody to go use high flow nasal cannula in your general care wards, but in their facility, which is necessary, this is one of the ways they calculate, or they trend values to prompt earlier conversations before the patient kind of gets really sick. They try to move them into the ICU. Thought that was an interesting use.
Absolutely, because it's not making a decision to intubate them. It's saying that clearly
Yep.
they're at a higher risk of intubation. Whether or not you use one value to intubate somebody is probably wasn't the point of that paper either. And that actually they didn't do that in the studies. So some people need to understand too that although it predicted failure, they just collected the data prospectively in patients with high flow nasal cannula. Then they looked at this index as a way to predict those patients that ended up getting intubated to see whether or not it would have predicted it. It didn't use it as a decision to intubate patients. Like, it wasn't that kind of study. It was a retrospective analysis of a prospective study, essentially. But they were prospectively just collecting the data on these patients and doing nothing to determine whether or not they're going to get intubated or not. They just wanted to see if any of the values they collected could predict that intubation. And this is where you get the cutoffs of this value. But as a criteria for escalating care and sending some, specifically if you're not using it within the ICU, I think it's actually a great use, because it doesn't require, like, you don't have to think too hard about it. You can be like, listen, this patient's, rocks in this. We started at high flow and 12 hours later, it's less than 3.85. We probably should put them to a monitored bed, and then they can make the decision based on other factors, whether to intubate them. Yeah, I think that's probably what most people should do.
I think what they do is they have their RTs calculate it. And again, this internally, this is not scientific, hasn't been validated, but internally in their facility, based on their circumstances, they know that if it's went up by, changed by a certain amount over time, it would prompt these earlier conversations. And I thought it was really smart as a way to catch somebody before they totally tank and then kind of emergently have to be moved into the ICU type setting.
Well, I think a lot of hospitals used to use like the absolute value of FiO2 as that criteria, that triggering criteria, like if you're requiring 60 or 70% of FiO2. But I think in the time where, we're starting to get, and I think COVID did this to us, we're more comfortable seeing patients on higher levels of FiO2, provided that they look like they're stable. This is a nice measure that can tell us if that stability is something we should be worried about or not. All right, I need no comments on the, we got a comment here. Rocks used, but not done correctly if the SAT's 100%. Yeah, again, similar to the SpO2 FiO2 ratio, if your SATs are 100, it's not a very useful tool.
Not only that, Tom, but if you're using for example, if you're using the bedside monitor to count your respiratory rate, those are always wild. I shouldn't say always, but those are many times wildly inaccurate, especially if someone's moving around and or has an irregular respiratory rate. So, as Pablo mentioned in his comment, it relies on a very accurate counting of the respiratory rate and understanding how they're actually breathing as well.
Yeah, not an 18 or 20.
Maybe, Keith, we can do a one of these Inspire conferences on bringing back the respiratory rate, making it important again.
Right. Yeah. Making the rate great again.
Please stop saying just the rate of 18 or a rate of 20. We have to stop doing that.
We're going to make blue hats that say
make respiratory rate great again. Please count.
Right. Let's see here. Okay, so these ones I think we should just hammer through. Keith, what do you think?
Yeah, let's do it. Let's hammer through it. So some of these other scores, like Tom mentioned earlier, they're really complex, but somewhere in each one there is a category for oxygenation and sometimes acid-base balance, right? So they are contingent on and take into consideration your pulmonary status or respiratory status. So some of them, basically, there's three different categories. One's a severity score, and we'll talk very briefly about each one of these. But the SOFA score, the sequential organ failure assessment, outcome predictors like the Apache. I think the Apache score is up to at least Apache 4 at this point in time, but I don't think there's a lot of really interesting changes to them. I may be wrong about that. And then some that actually may help you make decisions, and these decisions might be triage decisions, or when stuff's going down and you don't have enough beds and you have a lot of really sick people, et cetera, then they could be useful for that. So I can't see that. I don't know if.
Yeah, no, it's fine. I can go full screen too and see it. But basically, just to reiterate what I said earlier, how some of these more significant scores I mentioned also use PF ratio. So for clinical research, a lot of the time the SOFA score is one of those things that if you're using electronic records could be set up to possibly calculate automatically. They're used a lot as baseline characteristics in studies to see whether or not patients have been randomized sort of equally. You want to ensure that patients with, and specifically the Apache score, because this sort of tells you how severe your patient is, but then the Apache score kind of is a value that it's a scoring system that tells you really it's more of an outcome predictor. So let's say you randomize patients, and just by chance, again, because randomization really, you should end up, if you have differences between the groups you're randomizing, they should be by chance if you're properly randomizing. If one group has a higher SOFA or Apache score, then you can sort of look at that as a consideration. If there are significant differences in your results, you could say, well, unfortunately, randomization tried to take care of this, but it looks like more severe patients were in one group versus another. This actually happened in a study. I believe, it was actually an APRV study. They were unmatched in favor of APRV, but this is just unfortunately due to randomization. It's not. It wasn't the fault of the authors. But you can see it includes platelet counts, bilirubin, blood pressure, and whether or not they're requiring medication to help sustain that blood pressure, GCS, and creatinine or urine output. Anyone else want to make comments to that, or should we move on to the next one, Keith, you think?
I mean, I think we could just move on. Yeah.
Yeah. This one might be even harder for you to read if you had trouble with the other one. So I can run through what's in this list. I've got a full screen on a big monitor here, but essentially we got rectal temp. So right away, RTs don't calculate this one. Mean arterial pressure, heart rate.
Above the diaphragm.
Yeah, exactly. It's not above the diaphragm. Mean arterial pressure, heart rate, respiratory rate. So there you go, Brady. We got the rest rate in here. Oxygenation, and it's looking at whether or not they're on an FiO2 50 or above, or less than that, and then also looking at PO2s. And we got arterial pH, bicarb, potassium, sodium, creatinine, hematocrit, a little bit of TLC, and GCS. Don't ask me what TLC is, because all I can think of now is tender loving care. I can't even.
I thought that's what you meant.
Yeah, no, it's just TLC. And then the news score, maybe you want to, Keith, do you have some familiarity? Does anyone actually, maybe not just Keith, I don't have a lot of familiarity with this one. I've not used it, although it might be in the chapter I wrote in Egan's, but it's not something that I have personal experience with.
So what I've been told is that this scoring system is popular in Europe, particularly in the UK. And
is anyone in the chat using this?
I talked to an intensivist that I know from the UK, and he said that they primarily use this scoring system to sort of as a comparator between institutions. They have like 16 hospitals that sort of share data, and what they really do with it from that point is not something I understand, but just to compare different severity of illness and different ICUs there.
We use a version of this, Tom. I don't know how robustly, but we can pull it into our Epic where it shows up on our main Epic screen. It's called the MEWS, Modified Early Warning Score, and it's a little bit simplified version of this, but it's basically one of those things where if the number is, below a certain amount, below a certain level, and it's a 0 to 10 scale, if I remember right, and it just means, hey, if it's below this number, the combination of factors that go into it tells you that the patient's decompensating or has reached a level that you should probably check on them. So it's a way to, I guess, kind of, and it pulls things that are already charted in Epic by other disciplines. So then it kind of lets us, our eyes just sort of wander to those low numbers if it's somebody that's not already on our radar, and we can go there and, make sure that it's accurate and make sure that it's, the patient actually is decompensating. IPI, Integrated Pulmonary Index, is one we did some research on here that's kind of along those same lines, where it just pulls a few different things in, and if the number is trending in an unfortunate direction, it kind of draws our attention to those patients versus, trying to keep an eye on everybody.
Yeah, Tanya's saying it's built into many systems, because this is definitely one of those things that could be pulled if you have an electronic system. That could easily be, and again, the whole idea, it's supposed to be an early warning system, right? So it could just pull this data and then give you a warning about a patient. That's really where it shines. I think someone manually doing it is not going to be as effective as something that's automatically triggering it. One of the questions we have here is actually, we're going to talk about the HACOR score, which interestingly enough, this score has a lot of the items that are on the HACOR score. So HACOR is heart rate, which this has pulse. It's heart rate, acidosis. This one does not have pH, but acidosis is one. Consciousness is the C, O is oxygenation, and R is respiratory rate. So this has quite a few of those things, a little bit less detailed in the consciousness. We don't actually have a slide prepared for it, but I do have a paper sort of called up if we want to just hammer through these last. There's just that and GCS. I can bring up the HACOR paper, but we got 3 minutes left, so I'm worried that we're running out of time. Maybe we need to do a whole thing on the HACOR score.
Yeah. Or we
I'd
can
be
do
down.
something a little more focused.
Yeah.
Yeah, the battle score is a score that's used in trauma to evaluate chest trauma, primarily rib fractures and pulmonary contusions, to determine, at least at UVA, we used it to determine whether or not somebody was going to get admitted to the ICU based on it's based on age and rib fractures, et cetera. So you can sort of anticipate that an elderly person with multiple rib fractures is going to have more problems than, somebody that's in their youth. So that's what it was used for at UVA.
I just asked the chat maybe if people would like us to do a predicting NIV failure as a topic, because there's a number of papers on things that are linked to NIV failure. And again, we could keep it broad and do respiratory support failure, so include high flow, or do one completely separate with high flow and then one for NIV, because there is some crossover in scoring systems, but a lot of them typically are geared towards one or the other.
Right.
And then this question just came up. Do you use Battle with the PIC score? Anybody?
No, I'm not familiar with it.
I think this was the last one, which I imagine most people know what GCS is. Definitely used a lot in clinical research. It's also used in some predictive scores for failing NIV, for example. And the requiring of an airway, obviously for airway management, GCS may be used when to decide to intubate somebody, clearly in the emergency department.
Yeah, I think
I'm sure paramedics use this quite often as a decision tool for requiring an airway.
Yeah, I think most people are probably familiar with it. The one nuance I would like to just go over real quick is that, originally the GCS was developed for people with head injury, head trauma, right? And so, let's say you have a GCS of 6 and your criteria says intubate somebody with a GCS of less than 8. It sort of depends on why the GCS is 6. Is it because they've been in an MVC and they have this diffuse axonal injury and they have traumatic brain injury, or are they a GCS of 6 because they've overdosed on heroin. So those are two different patients. The overdose patient may, get a bunch of Narcan and be okay, whereas the TBI patient is not going to get okay within a short period of time. So I think there's some nuances. People have have used the GCS now for patients that it really wasn't intended to be used for. So that's just something to think about.
Yeah, and I think we've all put a patient on BiPAP with a GCS less than 8, who was a frequent flyer to the emerge department. With before you even do a blood gas, their CO2 is probably over 80, maybe over 100, but they've been there every 2 months for the last 5 years. These are the patients that, despite GPS suggesting you should intubate, you give them 10 minutes of BiPAP and they're demanding lunch.
Yeah, we actually discussed this in depth, I think, during our NIV panel.
We did, yeah.
Yeah.
Did we do an NIV failure one, or did we just do a general NIV talk?
We did a general NIV, a general high flow, and then one that was combined. And I think we covered some of this stuff then, but
Right.
there may be some utility in specifically talking about anticipating failure in any of that.
Right.
Yeah.
All right, we're at 2:00.
All right. To sum it up, scoring, I can't see it, but I'm going to
Do you want me to read it?
get a
Keith?
little closer. To sum it up, scoring systems are helpful, but only as tools used in conjunction with your clinical judgment and experience. As populations change, scoring systems will have to adapt to those changes. Our population is becoming increasingly elderly and more frail. Frailty index is another one we didn't talk about, but it's interesting. As more and more data become available with more computing power, we can use more complicated and comprehensive scoring systems to provide more accurate predictions. Joel, the future of AI integrated care is to take these scoring tools and translate them into alarming systems that demand assessment. At the end of the day, your assessment skills will be the best tools ever. I agree with all of that, for sure.
And we have another possible suggestion. Now, Keith did post a link in the chat. It's www.inspire-rt.com. And on that site, you can suggest topics. Is that correct, Keith?
Yes. Yeah.
There's
You
an
just go
option
there
to
and
suggest.
contact
Yeah, so go
us.
ahead and type in topics. Anytime you come across one, you're like, oh, this would be a good topic for these guys to discuss, and gals. Sorry, I don't want to use the word general guys, but oftentimes we have quite a diverse panel here, so we would be more than happy to discuss it. Any subject that you bring up, provided it's related to critical care, I suppose that's our one niche area, I would say.
Yes, agree. Yeah, so hit us up. Go to our website. We have a big resource page there. You can find lots of papers. We offer the daily pearls that we put on LinkedIn and Instagram, etc. And just go there, and you can go to the contact us page and recommend anything that you'd like to hear us talk about. Tom will send me a recording of this shortly, and I will post that on all the different social media outlets that we have available to us. And you are welcome to take that and share it with colleagues and your class and your department or wherever you think it might be helpful. So I'd like to thank the panel again for your time, your volunteering your time to help with these endeavors. And I want to thank the people that signed on and participated today. Thank you all very much.
Thank you, everybody.
All right.
All right, we're signing up.